All right. Well, Linda, thanks for spending some time with me this morning. Since
Absolutely.
you're going to be my guest lecturer for the Movement System Monthly live session next weekend, I wanted the Japanese physical therapists and also the other movement professionals to get excited to be able to meet you and ask you questions, quote unquote, in person. It's nice if they're able to put a face to the name. So
Sure.
I'm sure many of them have already read at least of some of your publications. So,
oh, wow, that's great. Good to hear.
Yeah. Could you tell us a little bit about your current role at Washington University in St. Louis?
Sure. I am a professor in the program in physical therapy in the Department of Orthopedic Surgery. And I currently am the division director for research. So we have, the program has three missions. One is research, one is education, and one is clinical care. And so I'm over the research division, and we're really about bringing people together who want to have an intensive research career, but also want to contribute to the field. And the division is there to facilitate their growth by giving them the kinds of resources they need to succeed, to build a research program that helps us understand the movement system. And it's also there to help facilitate collaboration among ourselves and other investigators on our campus, and then national and international collaborations. And so my role really ends up being a lot of mentoring through the process, because I've learned through my own career how to do that. But I think the other part of it that's unique, or that I like about it, is that I'm both a clinician and a scientist, and so I try and make sure that whatever our faculty are investigating in our division, that they're disseminating or giving that information to our new trainees, both PhDs and postdocs in movement science, but also our doctoral students in clinical physical therapy. So everything that they're doing, we make sure that anybody in the division is really communicating what they're learning in their specific research program, what they're learning and why it's important to clinicians. So they're teaching also in the clinical DPT program here. And so my role is really to make sure that people are mentored to do a good job in their research, but also to really communicate that information so that our trainees are getting up-to-date information about what's important or what we're learning about clinical practice, both assessment and treatment, as well as basic science that might underlie what we're doing.
Yeah, I think that's the wonderful thing about having those three major areas and how they're so beautifully connected at WashU. I've always appreciated that about all of our faculty there. So
yeah, I think even the clinical, I'm very focused right now on the educational division and how we're communicating with them, because we're starting a new curriculum that's competency based. And but our clinic has really, the nice part of the clinic is we have many of the clinical faculty who also work in our labs. So they're taking back what we do in the research division into the clinic and implementing anything that we know has a pretty solid foundation. So yeah, it's fun. It's very fun, because you're not just doing science and hoping for the best that it gets communicated. We actually can impact clinicians, both people practicing and or educating people in the field. Yeah, it's fun.
Beautiful. I think I recall you telling me that you used to treat neurological patients before, but I know that that's currently you do musculoskeletal pain related research. So how did you transition from treating neuro patients to researching about musculoskeletal pain?
That's a great question. So I fell into treating patients with neurological dysfunction. So most of my career, I was a clinician for about 8 years before I went back for research training. And I happened to get a job, and somebody scooped me up and said, you know, I'm running the neuro division, come with me today. And that's how it happened. I'd done, you know, some clinical training in that. So I worked in neuromedicine and neurosurgery, and it was an acute care facility. And I loved it. And it was a unique situation in that we were right in the hospital on the floors, and we had a clinical space, and we had PT, OT, and speech all working in the same area. And then we had social work right down the hall. And then of course the physicians, because we were on the floor. So I treated those patients, and I ended up being I think they called it the supervisor of that division. And over that time, we developed a small rehab unit. We did outpatient PT for neurological patients, and then we did home health. So, and this all kind of gets to why I'm doing musculoskeletal. We had a continuum of care so that you could see, because these people are mostly people who have chronic conditions, right? And so we learned how to treat them effectively and efficiently, because we could see how they behaved, not just in the hospital or in rehab, but how they were behaving in their home. And so that really helped us come up with an efficient way of treating. But the biggest thing I realized is that, at least at the time when I was a PT in this acute care facility, was that we didn't have a lot of evidence, particularly for how to treat movement and neurological dysfunction. We didn't have a lot of standardized outcomes, so that you could really track what you were doing and making sure that people really were improving in a way that was standardized, other than just using your opinion. So that's, you know, I just said, well, this is really a problem. So I decided, well, I'll be part of the solution. I'm going to go back, and I'm going to, you know, help contribute to understanding more about the basis of what rehab is, and particularly in terms of movement. But I also decided that you know, people with neurological dysfunction, I think, you know, the prognosis is quite different than with musculoskeletal, because they have a lesion of the nervous system. And so the idea was, maybe I could improve movement dysfunction in people without a neurological lesion, and maybe have a bigger impact. So I got research training in a lab where my mentor is an engineer and an experimental psychologist. The lab was about attention perception and motor control. So how, you know, what's the mechanisms contribute to how those interact. So I moved to musculoskeletal. I thought, you know, maybe the prognosis for improving movement might be better. And subsequent to that, I developed a research program around musculoskeletal pain, mostly spinal. I definitely, you know, we looked at people with neck pain, hip pain, pelvic pain. But we've mostly, our funded work has been in spinal pain.
Mm-hmm. Yes. Wow. That it's amazing to have that different backgrounds come together, and then, you know, finally reach this. I don't know if it's the final destination, but it's great to see. It should be focused research coming out. But
yeah, and we really actually, it's not just that we're looking at the patient as an orthopedic patient or a musculoskeletal patient, but a patient who the nervous system and the musculoskeletal system are working together to contribute to what the patient looks like. And then there's other factors clearly that influence it, but we're really focused on, so it does take you back to working with patients with neurological dysfunction and kind of trying to understand the nervous system and in its control of movement, but now it's with people who just don't have a lesion. So.
Right
Yeah.
on. So I'm really looking forward to next weekend's lecture. What can we expect to learn from you on August 22nd?
Well, hopefully you'll learn about what appears to be a pretty effective, a pretty efficient, and a durable way to manage patients who have spinal pain, low back pain, and the data is about people with chronic low back pain. So we're really also interested now in acute, but next week is about chronic. These people who have kind of up and down behavior over time, they kind of are dwindling in terms of their function. And it's really about how do you really target the things that appear to be super important to these people for long-term durable effects in terms of improving function. And so hopefully I'll sell you that this is something to really consider carefully in your practice and to perhaps prioritize in your practice, because there's a lot of different ways to treat patients, and we just don't want this to be lost because it looks like it's pretty important. So
yeah. Oh, and I hope the data speaks for itself as well. So
I hope
yeah,
so. I have a really nice, I think, graph of data from a prior trial we conducted and the one that I'll be spending the most time next week talking about. And the effects are twice what we got in the first trial, and also we get them much faster. We get them in 6 weeks instead of 6 months. So again, it's one thing is it's effective, but the other is it's efficient. And then I'll show that they last out to 12 months. So that I think it means you don't see as many, you don't see that patient coming back perhaps, but that's actually kind of a good thing, right? That's what you want. That's right. The goal, Yeah. And then you build your reputation on how well you're doing patients. And so new patients come to see you as opposed to the same ones coming back. Yeah.
Well, we look forward to next week, and I'm sure the Japanese movement professionals are very, very excited to see you. So thank you for your time.
Sure.
All right.
Great.
We'll see you next weekend.
All right. Thanks.